2012. So we're doing quite well. We've got a lot of work to do, and we want to try and encourage you to participate, because as I've said, it's to benefit you and keep a record about you and your disease so that we can monitor the progression. We've got some consent forms here today, and I'll be across at the table in the break, so if you want to come and talk to me about that, or any of the colleagues here today, we're willing to talk to you further about that. So what else is going on in our service? Well, as Jane's already talked about, we've got the exercise studies. We're assessing the benefits of exercise, and Professor Turnbull's in the privileged position of being able to stand back and assess all of us doing the work while he's watching us. He didn't actually get on the treadmill, I don't think. We've also got a patient satisfaction survey which we're trying to run in the outpatient clinic. We'll encourage you, if you're given one of those, to fill it in, because like I say, we want your suggestions, we want your comments, we want to make it better. So we use that as an opportunity to tell us what you think, and that's about the service as a whole in the clinic as well. And then we've got some, one of the other studies that's going on at the moment is finding out what's wrong with the muscle. Why have we got fatigue in the muscles? So we're looking at what's wrong with the muscles. So there's current trials on what's wrong with the muscles at the moment, which you can get involved in. Some future studies that we're interested in, that we're just trying to set up at the moment. It takes a long time to set research studies up. We've got to get ethical approval, so it takes a while. But what we've got in the pipeline for the future is a study looking at growth restriction in children with mitochondrial disease, and also a study in association with hearing difficulties associated to mitochondrial disease. And then also studies looking at what happens to the heart. What happens to the heart when we exercise? We've talked about exercise, so we need to look at what happens to the heart. As we've said, mitochondrial disease affects all of the muscles, and the heart muscles, one of those major muscles. So we're looking at that, and that involves some imaging. So that's a picture of someone in a scanner there. So we're continually asking questions, and we need you to tell us the answers to these. We need you to help us find the answers. Pregnancy, as I've mentioned earlier, we've done a previous study, and we've found out that diabetes and high blood pressure are quite common in pregnancy with mitochondrial disease. So we're looking into doing a further study, and what we want to develop is some care guidelines for obstetricians to improve antenatal care. Because as Jane had said, quite often you'll go and see a physiotherapist to tell you you've got mitochondrial disease and they've got the blank look. That goes for all the services really, and obstetricians might not come across a patient with mitochondrial disease who's pregnant, so we want to develop guidelines. Then the final one is about the control of epilepsy. That's quite common with mitochondrial disease as well, and the studies that we want to look at are how we can control the symptoms and improve the epilepsy. So there's a lot going on. So my final question is really to you. So how can you help us help you? As we've alluded to, we've got poster boards around the room. We've got a lot of colleagues here who are willing to help. We want to try and get you to join the cohort so that we've got as much information as we can, so we can monitor disease progression. So the team are here to talk to you about the studies. We've got the poster viewing. For those of you that don't know about the website, we do have a website, and it's updated regularly. There's a lot of excellent information on there, and just come and talk to us.
Thank you very much, Cathy. It's very difficult, isn't it? Because what the advances and what I think you put into context was that many of the advances that we take for granted, like going to the doctors to have an antibiotic, is something that came from research, isn't it? Yeah. And I think that's one of the things that people don't realise, you know, that if you have an aspirin to stop you getting pain or ibuprofen, it's all related to research that people have done in the past. And how much do you think, so when we're looking at the patients, when we're trying to give help for patients in the clinic, you feel that some of the research in the past has helped by giving us guidance, hasn't it?
Yes, absolutely. That informs us on looking at better ways of doing things. It's a continually asking the question, are we doing it what are we doing, what should we be doing? Are we doing it right? Could we do it in a better way?
And I suppose something else that I feel quite strongly about is that what we don't want to do is just provide you with the best care now. What we want to do is provide you with the best care for the future. And that can only really come through research, can't it?
If you take part in the research now, you might not necessarily benefit from it, but people in the future definitely will.
Yeah. Okay. And it might be in a short term.
Yes, yeah.
or
longer term.
Or longer term. Okay. Now, one of the things that we have to do, don't we, Catherine, with the kind of research is it's all very carefully controlled. Just, I know I don't want you to go on for 15 minutes here, but give some idea of what sort of regulations, what we have to do to get some of these studies through.
Okay. It's a long, drawn-out process, and it's all about safety, basically. We have to go through ethics committees, so when someone has an idea, someone in the team has an idea and a question that they want answering, we have to submit to ethics. You have to write a protocol about the whole project from start to finish. So what question are you looking to answer and how are you going to do it? And the safety mechanisms through the entire thing. So there's loads and loads of paperwork to do, committees to go through before they'll actually say, yes, we can go ahead with this. And then the recruitment process in terms of our paperwork as well, making sure that we've given you the right information, that we've obtained consent properly. There's loads of acts and parliamentary things that we've got to be mindful of, you know, if we're storing tissue, the way we take consent, whether you're able to consent.
So you would say that what we're trying to do is trying to make the researchers safe?
Yeah. The whole purpose of all of these is all of these checks. We see them as boundaries and barriers, but actually they're there to make sure that it's safe. So when we get to the point to ask you to take part in a trial, it's already gone through we've had to jump through loads of hoops to make sure it's safe before we even start.
Okay, and that's very true. We're talking a bit about the research that we're actually physically doing on the patients. In you've given a flavour for some of the studies. I think just as a point for people is to know that for many things that we do, there isn't a lot of evidence that that's the best way to do it. If people come to me and say, well, what's the best way to stop me getting heart problems? To be honest, we don't really know until we do research to find that out. And that's really important for people because we want to try and get in there early to try and prevent problems happening. So all of this work that we're doing is to try and give some evidence or some advice to people. I just want to say about the cohort study. So this is getting involved with that's not really onerous at all. That's just part of.
No, it's basically we've got some information about you in your medical notes, but we can collect some extra bits of information and hold it on the database so that we can, like I say, monitor trends, but it wouldn't mean that you have to do anything extra. There's no extra investigations or anything. It's just basically allowing us to keep that information so that we can monitor disease progression. And then, like I said before, if there's a study coming up that we know about, we've got the database of names straight away. We can identify who would be suitable straight away and then let you know about it.
Okay. Right. Has anybody got any other points that they would like to raise? I think during the break we'd be delighted if people would get themselves a drink. It's almost about five minutes it's going to arrive. If people would like to just wander around, it's important that we do engage you as much, that all of us that are involved here are involved with the kind of clinical teams as well. If people can wander around, ask questions. In particular, we've got one or two posters up which I hope will help you to try and understand some of the studies that we're doing. And what we'll do is we'll start again with Dr. McFarland in about 30 to 40 minutes to give people a chance to actually mix and get a cup of tea. Well, a cup of tea shortly.
I'll take the tea.
Catherine does the tea as well, so it's very good, Catherine. Thank you very much.